Well, thank you so much, everyone, for tuning in into another episode of Unabridged MD. This is Dr. Isabelle Hamid, your friendly rheumatologist. Today, we're going to talk about pain, and I am so thrilled to have Dr. Afton Hassett here with us today, and she is a pain specialist, works in the biggest institution in the US, and honestly, I want to say in the world when it comes to pain. And so we are going to learn so much. Tune in. You're going to learn so much about pain, whether you have a rheumatologic disorder or just chronic pain. This is for you. Dr. Afton Hassett, thank you so much for being here. For the people who do not know you yet, how do you introduce yourself? You are a pain specialist, but how did you come to this?
Oh, well, first of all, thank you for having me. It was such a treat to have you on our podcast too, on Chronic Pain Reset. And our listeners so enjoyed your story, your honesty, and your vision. So thank you. As for me, I'm a clinical psychologist by training, and I quite accidentally kind of found myself working with patients with a lot of chronic pain. And I just became so fascinated by, what level of challenge that added to people's life. And at the time I was a trainee, and so my supervisor said, if you're really interested, this is actually a great area for you. Why don't you go to the UCSD Medical Library, which is in San Diego. It's the University of California, it's San Diego, and just read a few articles on chronic pain and on fibromyalgia. And, I was hooked. I was so fascinated by the complexity. I had not thought a lot about mind-body medicine then, and I had not really thought about how behaviors and emotions and thoughts could actually have a physiological impact. And so I kind of became hooked then, and I studied, I made my dissertation now about chronic pain, and I studied fibromyalgia and rheumatoid arthritis and the role of depression and negative thoughts for my dissertation. And since then, it's just kind of been one thing after another that's led me to this marvelous point to be with this, this group at the Chronic Pain and Fatigue Research Center led by Dan Claw. And it's just an honor to work with such fascinating people. So here I am, pain psychologist.
And I'm so grateful for the work that you do. And you have a book. Do you want to tell a little bit about your book so that, we learn even more from your work?
Oh, absolutely. So first of all, I had no intention to write a book. It was, I think maybe we all think maybe we've got a novel in us somewhere, but it just kind of happened during the pandemic. And I just found myself not making the best use of time, watching way too many series and movies and over again. And I thought, there's got to be a better use of my time. And I work with some of the most remarkable physicians and neuroscientists and other psychologists and social workers. And, it's just this really rich interdisciplinary group. And I thought, what? Other scientists know about our research, but I don't think patients or clinicians know much about what we do. And then it occurred to me that, wow, this could actually be really helpful for people, who have chronic pain to actually learn what do we know about the neuroscience of it and how that can be leveraged to help them. And so that was kind of the impetus to write the book. And so the book itself consists of a series of chapters that are kind of tough navigating, maybe the first two chapters, because it is the neuroscience of pain. What is pain? And what do we understand about it from our brain imaging? But I hopefully have explained it in a really gentle way that feels, that's helpful and easy to understand. But then I go in and I talk about the marvelous science and neuroscience behind our thoughts and our emotions and our friendships, and how all of these play such a role in health and healing. And so I think it has applications beyond chronic pain to all health and illness. And it is kind of how we're thinking more about people, even at the NIH research level, where we're talking about whole person health now, which is wonderful. So the book kind of has this background, and then the real meat of the book is an experiment that I asked the reader to do. And that is to every day try a new behavioral approach to managing their pain. And these are all kind of evidence-based things that are everything from activity pacing to keeping a gratitude journal. And all of these things just impact different aspects of our pain, kind of a pain self-management. And then after the 30 days of trying these different things and kind of passing judgment on the ones they like or don't like, I ask them to pick the ones they love and to create something I call a thriving plan, which is just kind of a plan that starts with one or two of these activities they prefer, make a priority for which ones might be the most important to you, and then build on these over time and just really, really create an arsenal of tools that are tailored for the person because they like them and feel like it's what's important, and something they can do lifelong. And along the way, I tell a lot of stories. I think I have 13 lived experiences where people with chronic pain just share the most kind of remarkable observations they've had or insights they've had. And it's just, hopefully it's a beautiful experience. That was kind of the goal. And I'm shocked by how many clinicians now are using it because they said, oh my gosh, I can't explain this all to my patients. But if they're willing to read and to kind of spend the time thinking about this, they'll actually benefit too. So that's kind of a long story of how I kind of got to the book and what the book is.
And so I want to kind of unroll from there.
Yeah.
So the first question is, what is pain, right? It sounds like a simple question, but it's so much more complex than that. What is pain, and what's the role of our mind on pain?
Yeah. So pain is necessary for survival. Pain is a good thing when it protects us, when it keeps us from doing stuff that might hurt us because it will hurt. It stops us from, leaving our hand on the stove and causing irreparable damage to the skin on our hand. So pain serves a really important purpose. It is to some degree an alarm. The pain says, stop. Something is happening here. An alarm system goes off and you know that you're supposed to take some sort of action to decrease the pain. So pain is useful when you've injured yourself and you should not walk on that foot too much. It's useful when you have a lot of inflammation, say in your knees, and now you maybe have to go see the doctor because something's going on. The difficulty is chronic pain, because chronic pain often has changed what it is in the brain. It's no longer just this alarm system to keep you safe and to take care of you. It's a false alarm system. It's like somebody in your building keeps pulling the alarm system and it's like there's no fire. That's almost what chronic pain becomes. And the more we understand about the brain, the more we see, I get how the brain is doing this, right? So when other things can become alarming in our lives, intense stress, a really bad illness, some terrible thing happens to you emotionally, something you're really worried about, the brain kind of detects that as an emergency or an alarm, and it can set off that alarm system. And one form of the alarm system is pain. And so we take what we understand about kind of the neuroscience of pain, and we work with patients in a kind of addressing neuroplasticity training. Just means that the brain is malleable and can change. And there's many things that we can do to help people encourage these changes in the brain to decrease the experience of pain. And that's what these little activities kind of are all about. Even walking, even how we think about a pain, all of those can lead to better connections to make more pain or deconnecting areas of the brain to make less pain. So that's kind of the gist of what pain is and how it's different from chronic pain.
It's really interesting. It reminds me of a moment with my sister when I must have been like 9 and she is 2 years older. So she was 11 and I had hurt myself. I can't remember how. And then she takes me and she starts like pinching me. And I'm like, why are you doing that? She's like, because now you don't have the pain that you have.
It's different.
It's interesting because it worked.
Yes.
She's my big sister. So I was like, whatever she's doing is great, and she was right. It absolutely worked. And it's to me, pain is fascinating. So, I work with rheumatoid arthritis patients, inflammatory arthritis patients. So pain to me means so much. And my work is to really define, to figure out if the pain is inflammatory, mechanical, or as you mentioned, chronic, potentially coming from erroneous type of pain, right? So I think mechanical versus inflammatory is pretty easy. In terms of defining which one they are, discovering which they are. I think I want to talk about the erroneous, I mean, I don't know, like the chronic pain syndrome almost, right? Where
Yeah.
there is really not much of a reason anymore to have pain, but somehow it lives on its own. And I think the most obvious example of that is the how do you call that? The phantom limbs pain,
Yeah.
like when you have been amputated and you still have the pain. And I'm assuming this is how we started thinking of that, right?
Yeah. So yeah, this is so important. And it wasn't until really in the last maybe 30 years that we've really thought about, oh, there's different mechanisms, there's different things that are underlying the pain. And so in osteoarthritis, we know that there's kind of bone on bone grinding, right? That's going to cause pain. Inflammatory arthritis, like rheumatoid arthritis, the inflammation. But, rheumatologists always say that there's going to be a subset of patients with an inflammatory arthritis that they've treated aggressively and the inflammation is better, but the pain persists. What is that? And so we refer to that as, well, I guess we diagnose it as often having comorbid fibromyalgia, right? So now there's another pain process that's going on. And the way we conceptualize fibromyalgia is that it is a nociplastic pain condition, meaning that the nociception is really contained within the plasticity of the brain. So something has changed within the brain that is either amplifying the pain signal or is creating the pain on its own and like a warning bell. So that's a very different pain, right? Because if we look at the person who has fibromyalgia, they have widespread body pain. It's kind of everywhere. It's not necessarily tied to damage, though they could have something that's creating it, because we will see often people who have a hip arthroplasty because they've had terrible pain in their hips and widespread pain, kind of fibromyalgia. You replace the hip and everything kind of gets better. It's like, oh, okay, well, the fibromyalgia got better too. We can't account for that, but that's probably because the nociplastic pain was being driven by a lower stimuli. So that's what we call kind of bottom-up pain, right? So there's something that's happened. It's been there a long time. The pain signal is now strong. The pain signal is kind of admitting on its own. You remove the affected part, and that nociplastic pain gets better. But in a large subset of patients, it doesn't happen. We see this in arthroplasties in hips and in knees. We've studied thoroughly that a subset, about 10% of patients, will have persistent pain still in that knee or across their body, even after the affected joint's been replaced. So yeah, so there's, these different mechanisms can all be present in one person, right? Somebody can have an osteoarthritis process, a rheumatoid arthritis process, and fibromyalgia. So they can have all the pain occurring at the same time. And each requires a different approach. So it can be really difficult for rheumatologists, especially because they're dealing with these different types, to address the pain.
Yeah, and it's really interesting. I come back from, so now it's been more than 20 years I practice rheumatology, and at the early beginning when we were starting to talk about fibromyalgia, and everyone was like talking about fibromyalgia, right? And I remember some doctors who would be like, this is in the head, right? Like it's the equivalent of a hysteria because more women have fibromyalgia than men. And so then it was like, well, we used to call it hysteria, now we call it fibromyalgia. I remember a doctor saying that. And it's really interesting because the way we treat fibromyalgia is by, like, it's the same than treating neurologic pain, right? And I remember thinking something's interesting here. Do you know? So I've always wondered, right? Like, what's the history of the person who thought of, I'm gonna check the skin and see why, like, if there is any decreased nerve ending in there. Do you know the story of this?
So there are researchers that are very interested in that there's some change in how the nociceptors are working in the skin, and they have some interesting data. And I think that it could explain a subset, but a small subset, right? It isn't as widely observed as one might think to be a good explanation for fibromyalgia. So to us, it keeps coming back to the brain, that the changes in neuroplasticity, and the way now that we're starting to feel like we're being vindicated is with some of the new approaches like pain reprocessing therapy and EAET and all these other therapies that really focus on changing how the brain is processing pain, kind of through an exposure paradigm. With those patients, we see remarkable changes in their pain. Yes.
So I want to just go back to the nerve. So what I'm because I tell that story and I really want to go into this whole brain plasticity and all this because it's so exciting, really. What I was trying to get to is, and I say this to my patients, which is like, we used to think fibromyalgia was all in the head of people, right? That it was almost like a psychiatric disorder, right? Like in some doctors thought it was a psychiatric disorder. And to me, what's really cool is to think that there is someone that did the biopsy that said, well, this doesn't look like it's like on an EMG, we cannot say that this is polyneuropathy. We cannot say that this is neuropathy. Yet, if you do a skin biopsy, you see that there's less nerve ending. And so it's kind of like that shut up completely the whole group that thought that this was just psychiatric. And that literally send their patients to psychiatrists saying that this is not mine. You go and see a psychiatrist, which is so, I'm so glad we're going away from this type of medicine. So that's why, and I was wondering if you knew who had first done the skin biopsy, because to me, it's like, it was a game changer in the rheumatology practice, because the number of patients that I've seen being mistreated, at least, psychologically, just, well, this is your fibromyalgia, like, I don't deal with this, which is so dismissive. And, granted, it wasn't in the US, and we're a little bit more direct in France, but it was very painful for me as newly trained so that's what I was wondering. And then but I guess we're going to go to the next question, which is, all right, so there are patients that definitely have this small fibers neuropathy and we treat them, so it's not
right,
it's okay. But there are other patients with fibromyalgia, which is just this big, like it means everything and nothing, right? Who do not get better with the treatment of neuropathy. And so, can we go into this? Can you tell us what you know? And I think, and I want to make sure for the auditors, when we're gonna talk right now about fibromyalgia, can we say that we're talking about just chronic pain that doesn't have maybe like a stimuli, like there's no stimulus from the extremities or like the rest of the body, but it's all in the brain? Can we say that even if it's not labeled as fibromyalgia, this will work for other type of pain?
Yes, and you're actually nailing where we are kind of in our pain science and conceptualization. So we almost don't need to say fibromyalgia anymore, because there's so many people on the spectrum that have this nosoplastic pain. That is what it is. It is driven by hyperalgesia, so something is felt as being much more painful and is kind of amplified, or the pain is just fully generated by the brain, and then it's shooting out throughout the body. So that can co-occur in almost any condition. We study this in everything from dry eye syndrome to cancer to kind of post chemotherapy symptoms to throughout surgery and OBGYN in the context of endometriosis. I mean, every context seems to have a subset of patients that have this pain, and they don't all meet criteria for fibromyalgia. And we have shown in our studies in perioperative settings that just having a little bit of a fibromyalgia like the sensitivity sets you up for the likelihood that you will have chronic pain post-surgically, use more opioid medication because you're still in more pain. So it is on a spectrum. And so we all kind of fit somewhere on this sensitivity spectrum. And what we also see, and this is so seconded by our patients, that tell us, duh, but what it is that we have, our patients seem to have a broad sensitivity. So it's not just pain that they're sensitive to, it's light, it's sound, it's odors, it's tolerance of medication, it's being in too wide or busy of a social area and feeling overwhelmed. It's kind of this wide neural sensitivity. And you're shaking your head like, yes, you've seen this or can connect to this. It's very, very common. And we're finding that almost more than pain, some of these wide sensitivities predict outcomes even better than pain. They tell us who is going to respond to what treatment. They're starting to tell us, who is going to have a more persistent course of recovery. So, we're just kind of in the genesis and the really early stages of understanding these data and how, it is kind of the central nervous system sensitivity that makes us more vulnerable.
Sorry, that's such an interesting field, right? And so since the brain has so much power, and if you have been on the podcast of Unabridged MD, like if you listen for a while, I always say this because we in physicians call it placebo, right? The placebo or nocebo. We don't talk about nocebo. Nocebo is just as interesting as placebo. But placebo is when you're giving a treatment, but really there's nothing in a treatment, but you're actually getting the benefit of as if you were getting a treatment. And we can see that in all of the different specialty in medicine, including infection, including rheumatology, including cancer, right? And so the power of the brain is so powerful. It's so incredible, and it's not very well understood. Can you tell us, and I think that this is, I'm sure you're going to be, I would love for you to basically tell us what you have found from more of the expert clinician, right? Like in your practice, what have you found that, can explain what we see and maybe the power of placebo? I don't know, right? And then what has worked for your patients?
Yes. So unfortunately, I don't see patients anymore. I have not seen patients in years, even though I'm a licensed psychologist, but I oversee people who see patients, and we provide care to patients, and I do clinical trials, a lot of them. And so what works? Was that was the first, was the second part. What works?
Well, so what do you think it is? What do you think it is in the brain?
Yes.
And I'm sure you don't have the final answer because it's still science that being figured out. But what do you think from your expertise? What do you think is the reason why some patients have this type of pain? And then what has worked? What do you think works?
So we don't have a silver bullet. It's so fascinating. So we do know that a large subset of people with chronic pain have trauma histories, have had adverse childhood experiences, and have had very difficult events in life. They've lost loved ones or had very stressful experiences. But a large subset of people in almost any medical condition have had traumatic experiences. You have to be careful that, not to say that it's all about trauma, because look at heart disease, look at cancer, you'll see these, these large numbers because it's just so common, but it doesn't mean it's not important. And a lot of people will tell you that their chronic pain began soon after something really stressful happened. It could be a bodily stressor like surgery or a really bad illness. It could be a divorce or a financial setback or a victim of a crime or something, that was really, acutely traumatic. So people will tell you that, but not everybody. We see a subset of patients who are really high functioning. They're professionals, they're well educated, they have a pretty normal history. We all have kind of craziness in our history, but they have a pretty normal history, and yet develop, a chronic pain condition. So it could be a slight accident that happened. So it's so diverse. And so this is why it's so important for us to think about personalized medicine and how we have to think about each person as a unique individual that brings all of these factors, all of this history, and then we can work from there. And that's where we start to have the best success, when we understand kind of who the patient is and then use those factors to tailor their treatment, right? So if somebody who has a lot of history of trauma and difficult things, we want a very different approach, maybe more psychology, because that can help support them if there's any PTSD or depression. If it's a person who had a physical trauma, a more PT-oriented approach is probably going to help. But if the physical trauma involved emotional trauma, then we think, maybe a behavioral therapist can help here too. If it's somebody who has just developed a fear of movement, which is a really normal response for many people who have injured themselves, then, again, behavioral intervention as well as PT. So, again, it's just, what brings this person to this point, and having to take an individualized approach. That's what works the best, when we can tease out what's unique about that person and tailor an intervention to them.
I really love this answer. Thank you so much, Dr. Hassett, for this. I find that it's a little tricky when you're in, especially when you're in the insurance system and you have, maybe not so much time with your patient to go deeply into their history and figuring out what's going on, and really like what happened maybe 6 months prior they developed pain. And maybe even so, that's the thing that I love medicine, and I think I will always be so fascinated by it, because we are, like, human bodies are not just bodies, right? Like, they are mind and body and spirit, and it's fascinating to me to actually see and hear almost the moment where something got triggered in their life.
Yeah.
And then they may have developed rheumatoid arthritis, and they may develop, an actual autoimmune disorder with pain. And my role, I think, always is to put them back in balance. And so you have to think about that, like, right? But I find it so hard. I used to find it really hard. Now I've embraced it, but I used to find it really hard in the insurance system to basically say, hey, I think you would need to see a therapist.
Yeah.
Like, how do you approach, like, right? So people come to you with pain.
Yeah.
How do you go from, like, look, you have pain, and you need help in therapy, which, by the way, I think everyone should have therapy. That's amazing. And it just does, yeah. That's my take on this.
I wish we had that. I mean, I think we're doing a better job, and I think therapy is becoming more acceptable, and people are much more aware of self-care, trying to meditate a little bit or do mindfulness and, just take good care of ourselves as far as exercise. I think we're more open to it. But boy, a person who comes in with chronic pain does not want the physician to say, I think you need to see a psychologist. I mean, that is so hard to hear, because it's often not true, but it can help, right? And I think it's all the timing. So if you're a physician and you're getting somebody's kind of history, and they do say, well, my mother died at 5 and I had a very difficult upbringing, you can stop then and say, wow, have you been able to get some support for that, or talk to somebody about that? And so you can just kind of crack open the door. And then I think patients tend to understand that stress makes their symptoms worse. And so when we couch these things in terms of stress, it's helpful. And there's so many things that we can do to behaviorally manage our pain. And there's just tricks and tips that are so useful. It's not that most pain psychology isn't really psychotherapy. It is just, hey, let me think about how you're thinking about your pain. What are things that are helpful? What are not? And here's some tips and tricks to help you better deal with your pain, decrease your pain, and, maybe get you sleeping better, and all these other important things. So, again, it's how we couch things. But you're right, it's very hard to get a nice interdisciplinary approach. And I know that's probably why you've changed how you practice medicine, because the whole human is more complex, and you can't do it in 15 minutes.
Yeah, absolutely. Before we wrap up this podcast, I'd like you to maybe share a history of hope.
Yeah.
And I always ask my guests to choose, right? But in this case, I have a request, because I feel for patients who have a lot of pain, yet have no real reason for that pain. So there are reasons. So this is where it's tricky. There are reasons for the pain, but I think sometimes the pain takes over and puts their whole system in this stress reaction, which then causes actual symptoms that, heart rate that goes up, and, blood pressure that can change, and just feeling awful in general. Can you tell us a story of hope? Maybe you have many, and then you can say, well, here is a group of patients, but I have stories of hope in those patients, but you're a specialist, and I think it has so much value for those of you here that are listening to this to realize that there is hope, and you do not have to live in pain. So
Yes.
yeah.
Okay. Well, I love to tell you a story about actually somebody I can see, and I'm very comfortable talking about this person because she told her entire story on my podcast. So I'm glad to speak about her. But this is a person of note who had her dream job. It was absolutely the most marvelous job, and she was very high regarded, and she developed chronic pain. And the chronic pain became so severe that she had to actually step away from her job. And she was working in another country. And as a journalist, was actually kind of her first position before she took this larger position. She then qualified to come out to the University of Michigan as a Knight Wallace Fellow, which are where journalists come and they spend a year at the University of Michigan, and they work with others, and they develop special projects. And it's just this really lovely opportunity for journalists. And when she was in our health system, one of the physicians gave her my book, and she was happy to have it. And she reached out to me and she says, "Can we meet?" And so I met with her, and her name is Ulia Mendel, and she was the press secretary to the president of Ukraine, Vladimir Zelensky. And she told me her whole story. She says, this is a gift to be here studying, but I'm in so much pain. And her pain got worse and worse and worse and worse. And she said that, her physician finally gave her my book, and there were parts of it that just resonated, that nobody had said some of the things in the book to her before. And understanding how the brain works, she started feeling there was maybe an opening, that there was some hope. And so in working with us and with some of our, we're doing a pilot trial in pain reprocessing therapy, a derivative of it, with my colleague, Drew Sturgeon, who had, invited her to be in the trial, and she had a remarkable benefit. And she's what we call a super responder. So she went from basically not being able to write because her hands were in so much pain, to being able to do everything she needs to do and wants to do. And again, it was just cracking open that door that you have some agency. It doesn't feel like you do, but you are the controller of your brain. You can do something with your brain, and we're going to help you with some tools to do that. So to me, that just felt like an incredible story of hope. If you look her up now, she's got a fascinating Substack. She's still writing about Ukraine. She has pictures on Instagram, and she just is glowing. She looks fabulous. She's living her life. And no, chronic pain's not 1,000,000% gone. She, says that she deals with it, but she understands, and she is able to do things with her brain to decrease the disruption. And so that, to me, that's a game changer. When we're seeing these new therapies over the last 5 or 6 years, and how they can impact the lives of a subset of patients, it's just remarkable. So
can you, just for those who do not know those therapies, can you just give us a little bit of in a nutshell, what are those new therapies and where can people find them?
Absolutely. So the first one is referred to as pain reprocessing therapy, and it is a technique more than anything. It's just a straightforward way. In psychology, we think about it as an exposure therapy, right? Where we're having people kind of experience the pain, sit with their pain, become aware of it, move through it, and just tell the brain, through the safety. They could say putting on like your goggles of safety. You're not damaged. You're able to move your neck. You're able to move your hands, whatever it is. And people start to actually overcome it. It's a little like some of the work that's done with phantom limb pain, where we have to kind of trick the brain into not sending those pain signals, kind of make the person think that they have a foot there now. I mean, there's all these really fascinating
Mhm.
things that we have to kind of do. And so that's kind of what pain processing therapy is. With the way we practice it, we do a very brief protocol of just kind of three different sessions. And at the end of that, we will track people over time, and often they get it or it doesn't really work for them. But those who get it are like, oh my goodness, it's like a light switch went off. And so that's kind of one approach. There's another approach that is a little bit more in depth. It's called EAET, and it's I always blow this, emotional. I'm going to have to look it up. I'm so sorry, Isabel. I'll give it to you. We can loop around.
Yes.
And so EAET works through emotional expression that is often kind of buried in some people. So this is a really good approach for therapy for people who had trauma. And this enables people to be able to
emotional awareness and expression therapy.
Yes, thank you. Emotional awareness and expression therapy. It's so funny, we use our acronyms so often, sometimes we forget what the
I'm with you on that.
original intent is. But this is something that was put forward by colleagues and friends of mine, Mark Lumley at Wayne State University and Howard Schubiner, who's somebody I've known for a long time now. But he's a physician, and Mark is a researcher, a psychologist by training, and they've just developed this much more comprehensive approach. But both treatments kind of work on the same principles of really kind of helping patients, rewire or change how the brain is reacting to stress and emotion. So quite exciting. So hopefully that springs hope. It works for people who have had pain for like 20 years, and it's just amazing to see.
I really love that. I because I'm not a pain specialist. I'm just a but I'm a rheumatologist, and for me, it's anything inflammatory we can take care of, right? And sometimes it's just, I think it's really seeing my patients potentially spiral down because they have pain and nothing seems to work. And, yes, we can take care of the inflammation, but then what happens when they still have pain, but it's not inflammatory? And so, like knowing that they have agency, they have agency, and it's just a matter of learning a new technique. And I always say that if we can have Olympians achieve the result that they do, we certainly can take care of pain. It's not, and we just need the proper coach that can get us there. So I really, really love this. So again, we'll put everything in the show notes. You will let us know about the specific episode on your podcast.
We will.
And and then if you have where can you tell us about your podcast? Where can we listen to it? And then in general, where can we find you and your work?
Excellent. Well, thank you for this. So the podcast is Chronic Pain Reset, and you were a guest just a couple episodes ago, and it's just a beautiful episode. Again, loved your story. That is on Apple Podcasts, Spotify, or wherever you get your podcasts. The book is the same name, Chronic Pain Reset. It's 30 days of activities, practices, and skills to help you thrive. And that's available. You can just grab it off of Amazon or Barnes & Noble online. But please actually visit your local bookstore. I love independent bookstores, so please ask them in person. And then I'd be glad to add some links too. If you have show notes, that'll link you to more information about the therapies I mentioned. And I have to also have a shout out to Dan Klum, my colleague who's a rheumatologist also, who has probably done more than anybody to change how rheumatologists view pain and the openness and embrace now of patients and their complexity with their fibromyalgia on top of their lupus. And so, it's incredible.
Very kind. I agree. I loved his lectures on fibromyalgia, and I've had the privilege of seeing several of his lectures. Not many. I wish many more. But thank you. It's been a pleasure to have you on the podcast, and I would love to have you again when find some time. I'm sure you have more books that you want to write. Hopefully, no pandemics coming up. But it's been a pleasure. To our listeners, thank you for listening. If you're listening all the way to now, please make sure to share this episode with someone or many that you think would benefit from this episode. It is time to remind and tell everyone that there is a lot of hope in chronic pain syndrome and pain in general. And thank you, and subscribe. And until then, thank you so much. Have a wonderful week, and we will see you next week. Thank you.